Okay. Okay, take it away, Lynn.
Okay. Thank you, Francis. And okay, let's pull this back up. Well, good evening, everybody. It's nice to be with you this evening. I'm here in the Atlantic coast, so it's 9 o'clock my time. It's almost my bedtime, actually. So if I nod off, I apologize, but no, I'm just kidding. I'll be fine. But it's always great to have an opportunity to speak with a group such as yourselves. And I'm really thrilled to see so many of you interested in standards. And it's a great contribution for you to become experts in this area. We certainly need people who have expertise and understand the benefits of standards. So what I'm going to do tonight is give you just a very quick overview of some of the work that we've been doing, a little bit of a historical perspective on some of the activities that have happened over the course of a few decades now. As Francis said, I have been involved in informatics for probably 30 plus years of my career. And I'm sure some of you wouldn't even have thought informatics has been around that long, but it has. And certainly it's been a terrific career path for me. And it's been very exciting work and very groundbreaking in many regards. And I would say that you continue to be pioneers in this area as you embark on your careers. I think that there's still lots of ground to be broken. And so I encourage you to continue, because this is a very rewarding area of work, and you can contribute significantly over the course of your career. So I wanted to start just with a little bit of history. And some of you who've heard me speak before, I saw a couple of names I recognized, will know that I've used this quote over the course of many years, and this comes from Florence Nightingale. And, you know, you look back over the course of time, and almost 250 years later, we still have a problem in terms of being able to share and compare data across not just hospitals, but across the healthcare system. And that's not to denigrate any of the work that's being done by CIHI or the Canadian Institute for Health Information. But I think we still have a lot of work to do in terms of having comparable, shareable data. So this really is the lens that I come at this from, and I come at it from the lens of someone who's worked as a clinician, spent the better part of my career with a foot in academia and a foot in practice. So this presentation that I have for you tonight sort of brings a little bit of my practice background as well as some of my academics. Please interrupt at any time if you have a question. I'm going to keep this interactive if at all possible. It's hard sitting here talking to the computer. So if you do have comments or questions, I'd be quite open to having those throughout the presentation. So Florence Nightingale actually was what many of us regard in nursing as our first nurse informatician. And she had an uncanny ability to gather data and very tedious processes for gathering data and trying to compare statistics. So she was also a statistician. And one of the things that she's most renowned for is her famous rose diagram. And some of you who are familiar with the nursing informatics community will know that the CNIA, the Canadian Nursing Informatics Association, has a pin stylized after the rose diagram. And just very quickly, I mean, you can look at this afterwards for yourself, but she depicted data in this manner to show how many people were actually dying from things other than war wounds and in battle, but people who were dying from things like poor nutrition, infection, poor ventilation. People were dying in hospitals from many assorted and sundry things other than their war wounds. So she used this depiction to actually present to the British Parliament and make a case for improving the conditions of hospitals. So that's just a little bit of a historical thing for you to take away. And I must say, I used Nightingale's work over the course of time because it still resonates. She was very prescient, I think, in her work over the time that she was working in the field and contributing to not only nursing, but hospital and healthcare in general. And this is a quote from another set of colleagues out of the US. Clark and Lang, they wrote an article which is known as a seminal piece and has been referred to, and you can see by this now, this is a almost, 30 years old. It is 30-year-old piece and still resonates today. But basically what they were saying is if we don't name what it is that we do, it's going to become very difficult to control it, finance it, teach it, research it, or put it into public policy. So if we use different terminologies for the same thing, and we don't name our practices consistently, it becomes very difficult to describe them or aggregate the data. So I'm going to get a little bit more into that. But again, I think this is a really important quote to keep in the back of your mind. And their work actually was back in '92, and prior to that even, trying to develop an international classification for nursing practice. And that, of course, evolved over time to something that some of you may be familiar with, ICNP, or the International Classification of Nursing Practice, which is housed out of the International Council of Nursing in Geneva. And I must say that, unfortunately, there hasn't been a lot of uptake of ICNP, and it is a broad classification scheme that accounts for nursing assessments, interventions, outcomes related to nursing care, and also looks at intensity, meaning what volume of hours of care are required by individuals. Or so really, they started to classify some of these elements of practice and put standardized terms to them. And that work continues to evolve, but it's now coming under the auspices of SNOMED. And so I know you will be hearing from those folks in the weeks ahead. So I think perhaps next week is Linda speaking. So I think just for those of you who are not familiar with the sphere of nursing in Canada, we do have in excess of, it's actually more like 400,000 these days, but notwithstanding all the shortages that we're facing post-COVID, we do have a significant number of practitioners in the country. And so if you think about the volume of users, nurse users, they are the highest constituency using electronic health records in the country. And nurses practice across the care continuum in every care setting. And one of the things that we've been endeavoring to do is to make sure that nurses in their practice and in their documentation are capturing the essential clinical data that helps us understand what is making a difference in care outcomes or not. And, you know, we see this as a way of supporting overall having a consistent record that can follow an individual through the course of their life. In recent years, in fact, just a couple of years ago, we developed this infographic, and I'm going to give you a reference shortly that will bring you to a lot of the details that I'm going to skim over tonight. But if you're interested in reading more about any of these areas, there is a site on the Canadian Nurses Association webpage where you can read about all of these things. But one of the things that we've been spending a lot of time on, and I say we, I have a core group of colleagues that I've been working with, and I did mean to acknowledge Peggy White at the outset of this presentation, because Peggy and I have worked very closely together for 2 decades now. And in the last 6 years, we have focused on national discussions around what needs to be done differently in terms of nursing documentation, but we've broadened that as well to think about, it's not just about nursing documentation, but it's about clinical documentation across the board by all disciplines. And so we created this infographic, which was really focused on advancing what we think should be an essential data set across the board in every care setting, so that we do have shareable, comparable data. So if you sort of follow this infographic, it basically says that we want to be able to arrive at evidence that tells us whether or not we're providing appropriate care outcomes or positive, negative, what have you, and to really look at what needs to change in practice if outcomes are not positive. And I think the bottom line here is that we want people collecting and recording data once and having it used multiple times. And the other point I want to raise from this is that, you know, we collect an awful lot of data, but again, it's not data that's terribly useful when it's variable from site to site and from sector to sector. And if you think about the amount of data that nurses gather, so these are just a few stats that we pulled in putting this together. So over 2.7 million patients being admitted to acute care, and our work has largely focused on acute care, and I'll tell you why in a second. But if you think about the average admission, so when a nurse does an admission assessment, they interview the patient, they collect reams of data. And we did a study a couple of years ago looking at just admission assessment forms. And on average, we took forms from across the country, took a random sample, and actually found, you know, they ranged anywhere from a 2-page form to a 12-page form. And I say form, you could call that screens. A lot of this stuff still happens on paper in some organizations, though. And you think about the amount of time that nurses spend collecting that data. And then there was a study done in the States a couple of years ago that basically said only about 25% of that data is useful. So that really gives one cause to pause and think, what are we doing here? Because we have heard repeatedly, and certainly the conversation has been elevated in the last couple of years. We're hearing from physicians and nurses about documentation burden. So at the end of the day, it really needs to be about collecting data that does bring value to the care. And so we need to be very disciplined in thinking about what data we are collecting and for what purpose. Any comments on that or thoughts? I don't know if you're shocked by this, but I wasn't terribly surprised, but I think, you know, the time spent is really quite astounding when we look at the care hours that actually get delivered and the shortages that we're faced right now. We don't want to be using our scarce nursing and precious nursing resources to be collecting data for a significant portion of their day.
So Lynn, this is Francis here. I guess one question I have is just generally about documentation, because we keep hearing, you know, providers are really sort of overloaded with all these documentation requirements. Are we requiring clinicians to document more and more now, or has it always been like that? It just that somehow with the electronic systems, it's made it worse.
It has, and I'll tell you, I think it's become easier to create another screen or build in another form. And we haven't been disciplined in terms of looking at what's already being created and collected. And we haven't been disciplined to go back and say, well, you know, maybe we could streamline this. Maybe we don't really need to be doing this. Some of the data requirements are legislated, so we don't have a lot of control over that. But, you know, home care is a great example of where there's an inordinate amount of duplicate data gathering that's happening. And it's mind-blowing if you actually look at the amount of documentation done in home care. So I think, being somebody who in my past chaired a forms committee in a hospital, anyone who has had that experience or who is familiar with the volume, the sheer volume of forms created, and every organization creates their own variation on a theme. So this is going to be another message that I want to leave you with tonight, because again, if you think about it, across Canada, acute care is pretty much acute care, in the same way that long-term care and home care, I mean, those care delivery environments are not that variable. And where there are uniquenesses, that's not a good word, where they are unique, then it warrants looking for specific customized approaches to documentation. But by and large, we should be standardizing and streamlining documentation. So it is a bigger problem than it used to be, because seemingly we propagate more data collection in this electronic world. So I don't know if that answers your question, Francis, but yeah, I think it is a bigger problem.
Yeah, it does. Thank you.
So I just want to give you a couple of quick points around what has happened in Canadian nursing data standards. And I am focusing on nursing right here, but suffice to say that our work has evolved to be more about clinical data, not just nursing. So there is relevant data that applies not only to nursing, but to other health disciplines. So just sort of keep that in the back of your mind. But way back in 1991, and I was a lowly doctoral student at the time. And so I was invited to actually attend this meeting in Alberta, which was focused on nursing minimum data set. And the discussion started then. It had been happening in the US for quite a while prior. And a lot of the leading nurses at the time, not all nurse informaticians, because there weren't that many around, but there was a view then that we should be moving to these standards. Okay, so again, 30 years ago. And then in Ontario in 99, we actually received some funding from the government of Ontario. And the government was interested at the time in being able to quantify and cost nursing resources in a different way. And so what they did, they gave us funding to start to identify what were nurse-sensitive outcomes. And that evolved over the course of a couple of decades now to become something called HOBIC, Health Outcomes for Better Information and Care, and then subsequently CHOBIT, a Canadian Health Outcomes for Better Information and Care. And the Canadian Nurse Association website I'm going to give you has all kinds of information on this, so I'm not going to get into it in great detail. But we had a number of pilot projects that were run in Ontario, in Manitoba, and in Saskatchewan, in acute care, in home care, and we also did some long-term care, testing the feasibility of whether you could collect a standardized core set of data that would be relevant in every sector. So relevant in acute care, home care, long-term care, and even primary care. And that data would be consistently collected in these areas and would follow the person, so that longitudinally, you'd be able to look at some of those outcomes. And I'll share those specifically with you in a second. So you remember I mentioned the International Classification of Nursing Practice. And so we actually took the HOBIC measures. So there are 7 measures, which I'll highlight for you momentarily, that we mapped to the International Classification of Nursing Practice. And we also did a SNOMED CT mapping. And at that time, we actually contributed to both catalogs, because there were things missing in ICANP and there were things missing in SNOMED that were not being captured. And then we subsequently developed a pilot of a synoptic report that could actually graphically depict, similar to what Nightingale did, but to be able to depict some of these measures over time and just see how they were changing. We developed an ICMP catalog for ICN. And then we had another piece of work that was focused more on nursing administrative reporting, focused around things like hours of patient care, things like nurse turnover, sick time. We were looking at all those kinds of things that influence nursing resources. And that was a pilot that ran the course of, I think it was over a year. And we had 6 sites, and all of that data was collected on paper. So there was no consistency in that admin data either. And a lot of it was still being collected manually. So we realized we had a big problem there, and the standardization of how things were being captured, how they were being measured, there was no standardization. I see you looking, Terry. Have you got a question? Go ahead.
No, it's okay, Lynn. I finally finished running around listening, so I thought I would turn my camera on finally.
Oh, okay. Okay, thanks. So that was another piece of work that happened in 2013. And then we worked with CIHI. I'll talk about that in a sec. We worked with CIHI to create a pilot project to see if we could actually abstract the CHOBIC data from the organizations that were using it. So they provided us with a special project field where we actually received abstracts from 2 pilot organizations, and that became part and parcel of the DAD, or the discharge abstract. And so we figured out that it worked, we could do it, we could capture that data. And we actually had a couple of pieces of research that were done, actually looking at this relative to other CIHI data. So our researchers who focused on this were able to look at things like hospital readmission rates. And we started to see that there was some predictive value in these measures, in looking at how soon people might be readmitted, whether or not they got into trouble when they went home because they hadn't been quite ready to be discharged. And so that pilot showed us without question that we could do this, and we could do it to the point that it would demonstrate great value to the system. And also thereabouts that time, we started our National Nursing Data Symposia, and we ran those until COVID struck us all into silence. And we did have a virtual symposia in 21, but in those symposia, what we did, we brought together nurse leaders from across the country. We had non-nurses as well. We had government people. We invited nurse informaticians from across the country. In total, I would say over the course of 5 years of symposia, we probably had included over 500 different participants. We also invited the vendor community, and we wanted them to hear the conversation about the need to build standards into the systems. And so we did have participation from vendors like Cerner and Epic and Allscripts. Meditech never did play, but the other big players, we had Orion, a bunch of them. I'm not going to remember everybody right now, but those symposia were really focused on how do we actually get some traction here? How do we get the attention of the decision makers? How do we make people realize that this is important? And at this juncture in 2022, Peggy and I are just now, we had a meeting yesterday, we're in the process of putting together a think tank for this fall. And so this is really, we're at a critical juncture. Peggy's retired, I'm about to retire, and something needs to happen or we walk away and nothing goes on. So I'm looking to you people as the future here. So I want you to carry this message, and I want you to go away after tonight and really give this some serious thought, because you are our future here. And so that's a bit of a timeline. I don't know if you have any questions. There's a whole lot of other stuff that happened in there, but I don't want to bore you with a lot of history. So if you have any specific questions, please jump in. If not, I urge you to go to the website that I'm going to share with you, and you can read lots more detail there. All of the Symposia proceedings are posted there as well, so you can see what we talked about. And I'm going to talk a little bit more about those in a second anyway.
Any comments, feedback, questions from the audience? Maybe I have one. You may be
Sure.
talking about that a little bit later on as well. So if so, then you don't worry about trying to answer it now, because I think one of the nagging questions is, with the CHOBIC, I'm still referring to terminology standards a little bit more narrowly. With the CHOBIC, and you mentioned about ICNP, and now there's SNOMED. These are seemingly, ongoing questions that, well, which one should we do? So maybe you can give some insights later on. That would be helpful.
Yeah, sure.
Yeah.
I guess, the bottom line there, Francis, is that I think they all serve a purpose. And, ICNP being sort of the broad umbrella of which countries like South Korea, Iceland, some of the Netherlands, some of the Scandinavian countries, they have adopted ICNP. But ICNP really is a reference terminology. It has been adopted by some as a basis for documentation, but I would say the uptake there has been limited as well. And I think the difference in our work is that we're talking about patient-facing data, and we're talking about data that can transcend boundaries of care. And SNOMED, I see, is in the background of all of this. So SNOMED, from my take on this, is what happens, the magic in the background behind the scenes. So, and I guess the group will hear more about that next time.
Okay, thank you. I see Bayan has a hand up.
Oh,
so
sure.
Bayan,
Go
would you
ahead.
like to?
Hi, Lynn. Nice to meet you.
Nice to meet you.
Just a question about NANDA. I'm just looking at the website, the Canadian Nursing Association, Nurses, and I see that CHOBIC, and NNDS, but I also wanted to ask you about NANDA. US NANDA is important. How do you have a correlation for NANDA in this roadmap, or as a standard? There is any equivalent? I know that SNOMED is helping a lot right now, but in the past, NANDA was the core of nursing documentation in the EHRs, and also this was like a gap between the doctors and nurses, that they were using a different terminology and different process also of documenting. And I think that I'm a physician myself, and when I was working with nurses, they have their own terminology. You have their own symptoms and ways to document stuff, and also, yeah, I agree that there should not be so much to document so many forms, etc., if they are not going to be consumed for another actor, right? From the caregiver, another part of the team, or the nutrition and dietitian. So I think that's important, but sometimes I'm asking about NANDA because in the past, at least when I was reading, that was like a blocker, the NANDA procedure or stuff, and that was not very, maybe welcome by the physicians. So that was my perception.
Yeah. NANDA is an interesting, I would say, another milestone in our history. NANDA has been embraced quite widely in the US, and I would say the uptake in Canada has been spotty. I think the whole language of NANDA, and for those of you who don't know what we're talking about, this is the North American Nursing Diagnosis taxonomy that was created in the US. people built their careers on this and basically created a set of nursing diagnoses to complement, the intention was to complement medical diagnoses. So you might have something like the patient has skin breakdown, or the patient has a knowledge deficit, or, I mean, there's books of diagnoses that were created. And I have to tell you, the language did not resonate well with nurses. And I know there are probably a handful of organizations in this country right now that still use NANDA as part of their charting approach. But I would say by and large, it has not been embraced here. NANDA was part of the taxonomy created by ICNP. So they had the nursing assessment, which was the equivalent of the NANDA. So nursing assessment being the nursing diagnosis. And ICNP also had the interventions schema as well as outcomes. We chose very purposely to focus on outcomes. And because the assessments, by and large, are consistent in any event. Nurses assess function, they assess symptoms, they assess pain, they assess safety risks like skin breakdown, risk of falls. And something that we introduced with HOBIC, and you'll see in a second, is something called readiness for discharge, which was a scale developed by some researchers out of the University of Toronto. And that was something that nurses never have done consistently. Well, they still don't today, except organizations that are using this tool. So NANDA would be the equivalent of assessing symptoms. And if you look at HOBIC, it's an assessment of initial baseline of an individual's status. And then you can think of it as outcomes when you assess the same measures at the point of discharge. So we still get our assessment and we get our outcomes. But NANDA as an entity, I don't think will ever be embraced in Canada. And it's just another approach to thinking about care planning and thinking about what needs to be focused on for a given admission. So I think we have a lot to do around that as well. Care plans, this is a discussion we had yesterday, was vendors should really be considering now generating care plans as a byproduct of the initial nursing assessment. So whatever gets assessed on admission should help generate the care plan. And that's part and parcel of the kinds of things that we've been talking about to get more benefit from the systems that we're investing in. I'm not sure if that answers your question, but I think the closest we have to an equivalency of NANDA would be the CHOBIC assessments.
Thank you. I have another question, but I will put it there by the end. Thank you.
And Lynn, before you move on, I think another person typed in the chat box asking about the symposiums, because on your slide, the symposium stopped at 2020. You now have the think tank. Is that meant to replace the symposiums, or are you still going to run the symposiums?
Yeah, I should actually have changed this slide because we did a virtual symposium in 21. And the think tank is really, it's instead of, and it will be a very select group of individuals. The other thing I didn't say is that our symposia, for all of the years that we have had them, have been supported by the Canadian Nurses Association, Canada Health Infoway, and CIHI. They have all been corporate sponsors of the event. So that's what enabled us to actually bring these groups of people together. And I'm going to say a little bit more about that shortly. So the think tank, to answer your question, yes, it will be instead of a symposium this year.
Okay, thank you.
So this is just a screenshot from the website that I've been referencing here. So I encourage you to go have a look. You can see there's our infographic. The Canadian Nurses Association and the Canadian Nursing Informatics Association put out a joint position statement, and it specifically focuses on nursing data standards. And that was done, I think, following our 2016 symposium. We also put forward a resolution after that first symposium. We put a resolution forward to the annual general meeting of the Canadian Nurses Association to see CNA actually embrace the use of CHOBIC, LOINC, and the InterRide tools. So we basically wanted to make a stand as a nursing community to say we endorse these standards, and that was passed. So that was a big step as well. So Peggy White and I, we put this diagram together after the first symposium. Well, that was actually in preparation for the first one in 2015, and we subsequently updated it. But this is really a depiction of our vision. And it is meant to say, you know, if we collect the same data at the individual level across the board in assessments, interventions, outcomes, who's giving care, we have a unique care identifier, we have hours of care, we know when adverse events have happened, reporting those in the same way. Thinking about being able to aggregate that data, if we report it in the same way, if we record it in the same way, and then being able to look at that at an organizational level, being able to compare one medical unit to another, being able to compare one hospital's outcomes to another hospital, being able to look at long-term care in one province versus another. I mean, imagine how valuable this could have been through COVID for many, many, many reasons. We could have a whole conversation about that, and being able to look at where care was failing. And then being able to look at that at a jurisdictional level, you know, to be able to see a big picture view of what's happening in your province, and then being able to look nationally. So not unlike other types of things that are standardized and how they get reported and captured. And CIHI does a great job with the information that they gather, but quite honestly, there is very, very little in the CIHI data holdings that would suggest a nurse ever touched a patient. And so that has to change. So if you sort of follow my thinking here, this is about collecting data once at an individual level and being able to aggregate that to be able to serve many purposes. So here's a little bit about the Symposia. So we, over the years, have had each year probably 100 to 150 people participating. And people came from every sector. We were focused primarily on acute care, but we also had home care, long-term care, primary care. We had Indigenous nursing there. We had, you name it. We pediatric organizations were represented. And it was really about trying to promote the adoption of a core set of standards. And so the Symposia conversations were really focused on how do we advance this? How do we move it forward in practice settings, in academic settings? How do we get nurse educators teaching about this to you know, future graduates? How do we get researchers interested in this? And how do we influence policy? So we actually had working groups in each of those 5 areas, and administration being also a very important one. And there's been a lot of byproducts of the work. We've had tons of publications. I won't bore you with all that, but this just gives you sort of our intentions in working with our partners and really looking to broaden the engagement so that we had more people thinking about this, not just Peggy and I and our core group, but really trying to broaden the buy-in for this notion. And so we've done a lot of talking about this. We've done a lot of sharing and publications, conference presentations, many over the years. So we've worked very hard at trying to tell our story and to impress upon people the importance of the work. So some of the outputs, one of the things I mentioned earlier was that we collected some admission forms and kind of looked at what people were doing across the country. And we actually developed one common admission assessment. We took all of these assessments we had gathered and we created one and said, okay, this can be done. We can reach consensus here, but it's a matter now of getting people to adopt it. Out of the administrative work, what we realized is one of the big gaps is that we don't have nurse leaders who have a lot of knowledge in the whole informatics area. So that work has been ongoing. We have developed a set of competencies for nurse leaders. We've been doing work with educators. We've had a number of research initiatives that have been completed. And then the resolution I mentioned to you. I'm just watching our time here. I have a little, just a use case that we use in our teaching and sharing with those who are new to this space, and just really talking about an individual coming into the system. And these are the CHOBIC measures. I'm not going to go through them all. You can kind of see what they are. They're pretty fundamental. Nurses capture these elements in most care settings, but we don't capture them consistently. But these measures have been standardized, the scales have been normalized, and we can look at them over the course of time. And if you think about it, the InterRide tools have had a lot of uptake, but they've also been mandated. Mental health, home care, long-term care. I know they're trying very desperately to get into acute care now, but these tools, the acute care tools, will be significantly onerous, I think, for nurses. So we're trying to avert that situation if we can. So if you take this guy with obstructive lung disease, we know through SNOMED that there are different diagnostic terms that could be applied, but they all roll up into that one code. And if we say, you know, this is what's happening in the background with SNOMED. So those of you who are not clinicians, you don't need to be a clinician to understand this example, but we see this guy, he comes into hospital, he gets assessed on his function, and all of those scores get coded, and that all gets put into his record. And so we see this guy present, and then we can have a consistent way, we could compare his case with other individuals with COPD. So you start to aggregate that. You look at it pre and post. So you look at him on admission, you look at him at discharge. You can see where the changes have happened. He gets sent home. The home care nurse comes in, has the same scales, looks at whether his function has deteriorated. Is it improved? How are his symptoms? Is his breathing worse? Is it better? Is he able to manage? Again, the same assessment happening across the board. And so if you look at this individual, and this would be, you know, this could be just a year, it could be 10 years, but you can see this individual over the course of time, how they're progressing and how their function is either improving or declining. And we also know that from our studies that we have some predictive capability here to know whether or not somebody is going to be readmitted to hospital in short order because we sent them home when they were still too short of breath, or we sent them home without good knowledge of their medications. And so you think about all that data going into the electronic health record and then being ported out to all the different people who will have an interest in that. It's consistent, it's the same across the board. And so right now, you know, we have all of these standards, we have the technologies, but we don't have comparable shareable data. And so until we actually have the adoption and utilization of data standards, we're not going to get there. So what it comes down to for us is making sure that we're using our precious health resources appropriately. Are we using the right type of provider in the right place at the right point of care? Doesn't always need to be a nurse. Could be a physio, could be an OT. It doesn't need to be a registered nurse. It could be a practical nurse. and so on. But really being able to look at what's happening with care handoffs, what are the things that we're doing that are working best, and really thinking about where is that care best to be delivered. Is it virtual? Is it home? Is it in hospital? And so there's a lot of benefit to be derived here. And I think really for you folks who are at the early stages of thinking about standards, there are tremendous benefits to be had. And I think one of the big ones that's now emerging is in the data science field, which you may be familiar with, but I think, you know, big data, we don't start to capture our nurses' contributions to care in a very standardized way, nursing's going to miss the big data boat completely. And we do know that leadership is important. We know that we need clinicians involved in these discussions. We know we need to partner across the board, and we need to keep talking about this. So not everybody gets it. And, you know, we've had many conversations with the folks at Chi-Hi. They understand, but it's not sort of top of mind. And so from our point of view, you know, if we can consistently look at the performance of providers, but also of the healthcare system by comparing consistently named and defined data, that will take us a whole lot farther than we are today. So that's it. It's my story in a nutshell. I'm still awake, so I'll take any questions you might have in the last few minutes that we have together.
Well, thank you so much.